Welcome to Roadmap to Residency. Today we are breaking down stroke for Step 2 clinical knowledge. This is not a full lecture on stroke pathophysiology. Instead, we are going to focus on how the board exam tests you on stroke, what the high-yield question stems look like, and the test-taking strategies that will help you pick the right answer on exam day. Make sure you have reviewed your stroke chapters in first aid and your question bank before watching this, because we are going to build on that foundation with strategy. Here is what we are covering today. First, we will learn to recognize the high-yield question stems for stroke that show up again and again on board exams. Second, we will practice deciding between ischemic and hemorrhagic presentations, because the next best step is completely different for each one. Third, we will master the next best step question format, which is the most commonly tested format for stroke. Before we dive in, make sure you have gone through your stroke chapters in first aid and your question bank. This video assumes you know the basics, and we are here to sharpen your test-taking approach. This is the single most important split you need to make on a stroke question. Is it ischemic or hemorrhagic? For ischemic stroke, the STEM will describe sudden focal neurological deficits like one-sided weakness, speech changes, or facial droop. You will often see risk factors like atrial fibrillation or carotid disease mentioned. For hemorrhagic stroke, the classic buzzword is worst headache of my life. You will see vomiting, altered consciousness, and usually a history of uncontrolled high blood pressure. The reason this matters so much is that the treatment is completely opposite. Giving Alteplase to a hemorrhagic stroke is a life-threatening mistake, and the exam absolutely tests this. Now let us talk about the clues that tell you what to do next. For ischemic stroke, the exam is obsessed with time. You will see the onset time stated clearly in the STEM. If symptoms started within 4.5 hours and the head scan shows no bleeding, think Alteplase. If it is a large vessel occlusion within 24 hours, think thrombectomy. For hemorrhagic stroke, the head scan is your answer. When you see blood on imaging, your priorities shift to blood pressure control, reversing any anticoagulation, and getting neurosurgery involved. Never give Alteplase when there is blood on the scan. Let us break down the 3 most common stroke STEM patterns you will see. The acute ischemic stroke STEM gives you sudden focal deficits, a clear onset time, and risk factors like atrial fibrillation. The hemorrhagic stroke STEM hits you with worst headache of life, vomiting, and severe hypertension. The transient ischemic attack STEM describes symptoms that have completely resolved, often lasting less than an hour. Each of these patterns leads to a completely different next step, and the exam expects you to know which path to take immediately. Let us work through this question together. Read the STEM carefully. We have a 62-year-old man with atrial fibrillation, sudden right-sided weakness, unable to speak. Symptoms started 90 minutes ago. The head scan shows no hemorrhage. Take a moment and think about what pattern this fits. This is a textbook acute ischemic stroke. The atrial fibrillation is the likely source. The head scan is negative for bleeding. And we are well within the treatment window at 90 minutes. So what is our next best step? Let us walk through this answer systematically. Step 1, spot the pattern. Sudden focal deficit, atrial fibrillation, no blood on imaging. This is ischemic stroke. Step 2, check the clock. 90 minutes is well within the 4.5-hour Alteplase window. There are no contraindications mentioned in the STEM. Step 3, eliminate the wrong answers. Magnetic resonance imaging would delay treatment and is not necessary when the head scan has already ruled out hemorrhage. Aspirin alone is not enough in the acute window when Alteplase is available. Thrombectomy is for large vessel occlusions and typically comes after Alteplase, not instead of it. The correct answer is B, intravenous Alteplase. Now let us try a hemorrhagic stroke question. Read through the STEM. A 55-year-old woman with uncontrolled high blood pressure, worst headache of her life, vomiting, right-sided weakness, and extremely elevated blood pressure. The head scan shows a hyperdense lesion, which means blood, in the left basal ganglia. What pattern do you recognize here? Think about what is different from the last question and how that changes your next step. Here is the walkthrough. The moment you see worst headache of life combined with a hyperdense lesion on the head scan, you know this is hemorrhagic stroke. And the most critical point is that Alteplase is absolutely contraindicated. If you see blood on the scan, cross off Alteplase immediately. The correct next step is blood pressure reduction. Current guidelines target a systolic pressure below 140 to prevent hematoma expansion. Lumbar puncture would be considered if you suspected subarachnoid hemorrhage with a negative head scan, but this scan is positive. Aspirin would make the bleeding worse. The answer is B, intravenous blood pressure reduction. This slide is your cheat sheet for the two biggest treatment decisions in stroke. For Alteplase, you need all of these. Within 4.5 hours, no blood on the head scan, no recent surgery, no active bleeding, and blood pressure controlled below 185/110. If any single one of these is violated in the question stem, Alteplase is the wrong answer. For thrombectomy, the key points are large vessel occlusion within 24 hours, salvageable tissue on perfusion imaging, and good baseline function. The boards love testing the extended thrombectomy window because many students only memorize the Alteplase window. No, both. This question tests transient ischemic attack management. The patient had a 30-minute episode of focal deficits that completely resolved. She has no current symptoms. Many students want to pick observation because the symptoms are gone, but that is the trap. A transient ischemic attack is a warning sign of an impending completed stroke. The workup needs to happen urgently, not in 2 weeks. Think about what could cause this and what you need to find. The correct answer is vascular imaging of the head and neck. Here is why. This patient needs urgent evaluation for carotid stenosis because if she has a high-grade blockage, she may need surgery or stenting to prevent a completed stroke. Observation alone is dangerous because up to 15% of strokes are preceded by a transient ischemic attack. Anticoagulation would only be appropriate if you find atrial fibrillation, which you have not confirmed yet. And waiting 2 weeks for an outpatient appointment could mean she has a full stroke before she ever gets seen. The answer is B, vascular imaging. Stroke mimics are a favorite board question topic. The exam will present a patient who looks like they are having a stroke, but there is one subtle clue that tells you it is something else. The most commonly tested mimic is hypoglycemia. If the stem mentions low blood sugar or diabetes with missed meals, check glucose before doing anything else. TOD paralysis after a seizure is another classic. The patient had a seizure and now has one-sided weakness, but it will resolve on its own. Complex migraine can cause temporary focal deficits with aura, and conversion disorder presents with deficits that do not follow anatomical patterns. The test-taking pearl is this. Always check glucose first and look for a seizure history. That wraps up our stroke test-taking strategies for Step 2. Remember, the board exam tests patterns, not just knowledge. Review the cerebrovascular disease and neurology chapters in first aid and your question bank. Focus on the diagnostic algorithms, treatment windows, and contraindications. For one-on-one expert tutoring and residency advising, visit roadmaptoresidency.com. Our tutors have been through this process and know exactly how to help you succeed. If this video helped you, please hit that like button and subscribe to our channel for more high-yield board review content. Good luck on your exam, and we will see you in the next video.